everyone. I feel a bit high up here, to be quite honest, but there we go. I'll plug on. So I'm going to talk today, I've been asked to talk about the common issues with brain tumour patients, and I actually had a good think about this to work out as a nurse the issues that I see or what the issues are from a patient's perspective or carer's perspective. So I've tried to sort of pluck out the things that I think are important, but well, I would like to actually know, and I actually went through some literature, and I don't think there's ever been anybody that's been asked what, from a patient's perspective, what they actually think of the main issues that they deal with, whether it is a patient or a carer. So can I just have a few people that tell me what they think their main issues are? I'd be interested. Anybody? What's that? Hi.
Lots of unknown things.
Yes, definitely.
Everything is an unknown.
Yeah.
It's a learning curve and it keeps changing.
Yeah, and yeah, that's one of the main things that I think actually. It's that overwhelming information that you get. So good, I'm glad that I've headed down the right direction. So as you said, I'm a care coordinator over at North Shores, and we see quite a few patients over there. So I've kind of broken this up to what I think are the initial things that go on, and then as you know, time goes on and you get down to a year, 2 years, whatever amount of time around the diagnosis. So as the guys said down here, I think the main issue, especially for the high-grade gliomas, the GBMs, the diagnosis is out of the blue. And when we looked at the mean age is usually a 52-year-old male for a grade 4 glioma. They're usually fit, healthy, working full-time. On the North Shore, there is a lot of CEOs and head of departments and things like that. They usually don't have any other medical issues, so it is very, very out of the blue and shocking for people. All the information that you get and the different terminology, the info is just hard to absorb. It's a completely different language. And the information's overwhelming. You know, you come into hospital, you either present with something out of the blue, whether it be seizure, headaches, you know, those sorts of things. You go down this pathway of surgery, and then once your pathologies come back, you get bombarded with a whole heap of different medical people, whether it be medical oncologists, physiotherapists, people like me, hopefully, will come along and see you, your radiation oncologist. So the amount of information that you get in a very, very short amount of time can be completely overwhelming, I think. And then, as I badger on about a lot of the time, I don't want to. I think, you know, if people have got some kind of care coordinator, it's good. I'm not fussed what modality they come from, but anybody that's going to help you navigate the system is got to be a benefit. And I know that there's some hospitals that just don't have any kind of system put in place where they are helping people through the system. So that difficulty around navigating the system with multiple different teams involved. And, you know, the one thing that I get really frustrated is when patients are between different hospitals. You know, I mean, if you had surgery, for instance, at RPA, and then you were going to your medical oncologist at Concord, but you're going back to RPA for radiation, and just that between the hospitals, and nobody's probably talking to each other, and that I just think would be an absolute nightmare for a patient and, you know, the relatives. So the main issues, just going back to that, I think, you know, it's around that presentation. It's generally quick. The onset of severe headaches, and I'd say most people present with something, you know, on this list. So whether it's that onset of a severe headache or drowsiness, nausea, vomiting, a sudden seizure out of the blue where you've never had a seizure before, confusion or speech changes where the family is sort of noticing some things and go and get, you know, I keep saying you need to go to the GP, you need follow-up. Personality changes, and if I don't hear this once, I hear this 100 times, where wives of patients where the husband's been diagnosed with a brain tumour, and especially the frontal ones, where things have changed a little bit in their relationship for a little while, and hindsight is a great thing, you know. So those personality changes, and where I've heard, you know, where the wife thinks the husband's having an affair because there's been a change in the relationship, and to some degree they're a little bit relieved to find out their husband's got a brain tumour because, you know, they're not playing up on them. But changes in mobility, the gait disturbances, the weakening of the limbs, and it can be those subtle things where you know, you go to make a cup of tea or a cup of coffee and you start to drop the spoon, the cup, and, you know, just subtle things like that. Or the vision changes where you go to get new glasses. You know, there's heaps of times where people go and say, need new reading glasses, and next minute the eye doctor's sort of saying, actually, I think you need to head off to emergency. The double vision and the loss of peripheral vision, all these things are usually quick. So it ends up that it's a really complex case management. So they're complex patients, and that's why I know that I've been doing this for quite a few years, but I do find that these group of patients are different from other cancer patients. You know, if you had a breast cancer or a liver cancer, your brain's not affected, so, and you can still drive, you know, you can still drive yourself to appointments and things like that. But when you've been diagnosed with a brain tumour, you know, we sort of say you can't drive, you know, a lot of the time you can't work, you know, sometimes the memory functioning, things like that aren't quite as sharp as they used to be. And then you've got seizures, you're on dexamethasone, you potentially get clots, and, you know, but you've got to come in for all this treatment. So they are really complex patients with a lot of things going on that, you know, can be out of left field as well, where, you know, I'm thinking of you, but where, you know, people are trying to have meaning input to help with the care, but are missing out on things that are actually going on. So they're very complex patients, confusing pathway, and obviously accessing lots of different services. So then I sort of thought I'd go on to the issues after the first few weeks of diagnosis, and I think this is when so this sort of stuff around loss of income, the increased cost of the drugs and the treatment, you know, I get a lot of the time when I meet people, they're already starting to stress out about, you know, the cost of treatment and how much it's all going to be. That inability to drive, where, you know, you have brain surgery and straight away that, you know, we say to you, you can't drive a car, but you've got to come in for all these appointments and daily radiation and things like that. And I think that goes around with that whole loss of independence and loss of self to some degree, where, you know, your whole roles within your family completely change, the relationship changes, you know, your intimate relationship changes with your partner, your children, your kids are taking on different roles, they're stepping up. So big impact from that perspective. And then the whole return to work. I mean, a lot of the time I think I try and access, you know, annual leave, sick leave, all of those sorts of things, and we do try and get people back to work, but I think especially for the high grade gliomas, a lot of the time they get to a point that they end up sort of saying, oh, we'll leave the work to be and retire from work, you know, because the overwhelming changes just make it too difficult to get back to work. And a lot of that's around the changes that have occurred. And to me, you know, long term, I find the neurocognitive changes are the biggest issue for patients, you know, moving forward. Helen Wheeler and I have these arguments about whether speech, she thinks, you know, not being able to speak is a mega issue, you know, and not, you know, the word finding and not being able to get out what you want to say. But you know, I suppose that comes into this a little bit, but I do think the neurocognitive changes are just massive. And whether it's due to the tumour, the surgery, the radiation, the anti-seizure medication, you know, you do end up having some kind of memory changes. And it's because of, you know, what your brain actually does with your functioning. So it's around your attention, concentrations, processing speed, you know, your memory, that high executive functioning thinking, planning, troubleshooting, things that you were able to do quite easily before. And I'm going to go on to this about this a little bit more, and it should tie into the next speaker's talk as well, because I do think it's important. So just a little bit around cognitive function. I do find in general most people have problems with short-term memory, and I think you've just got to get your head around that that's going to happen, and that's the way it is. So rather than sort of try and argue the point that it's not happening, you just put tools in place to make these things easier. So get phone pop-ups, diaries, wall calendars, wall charts, any of these sorts of things to help you. I mean, I've got pop-ups in my calendar all the time in general anyway. I mean, it's a normal part of life. But the difficulty with comprehension and understanding things, that sort of goes on with, that planning, that high executive functions, troubleshooting, reasoning. And I think if you're a carer, I've got a patient at the moment, for love nor money is he going to take his medication. It's got to be on his terms when he wants. And the problem is sometimes he's missing them altogether. But as a carer, you know the importance of taking these medications at these specific times. And, with this particular guy, I know he's gone days without his medication. So the stress on the carer that he hasn't taken his medication is massive. And I sort of say to people, rather than have a big argument, you've got to step away from the situation, walk away, come back in 20 minutes and try and bring the conversation up again about things like medications or the things that, they may not want to do. There's 2 ways to skin a cat, or more ways to skin a cat, so it's just about changing the way you do things. So that also the ability to plan and make decisions is a bit lost, and realising the importance of certain tasks, like paying the bills and paying your registration. I've had a couple of patients that, the husband who has the brain tumour has been left to pay the bills and the car registration isn't paid, and next minute they're driving around an unregistered car and little things like that. So those, importance of certain tasks. So I think the carer does end up with a hell of a lot on their plate, is what happens a lot of the time. And the frustration around the loss of speech or word finding difficulties, and then also the behaviour changes and lack of insight into the loss of ability or function. I think that's a big challenge when people don't realise they've got changes going on and will argue the point. So this diagram here just talks a lot more about, what each part of the brain does and why these things occur, and this can be affected by the infiltrative tumour. It can be from the surgery, it can be from the radiation, it can be from the anti-seizure medications. So banging on about that yet again, that frontal lobe does a lot with that movement, intelligence, the reasoning, the troubleshooting, your behaviour, memory, personality. Having said that, we always say that if you've got a frontal lobe tumour, it's probably one of the best places to have a tumour, because at least, in your parietal or occipital lobes where your vision is, and your vision, the way you interpret what you see is, if you've got complete loss of vision around one side, it just inhibits a lot of your perception, your mobility changes, things like that. And temporal lobe, amongst these other things like speech, memory, behaviour, is a lot of your movement. So you end up with physical deficits because of your mobility loss. So further on with the cognitive function, and as you can see, this is one of the biggest issues that I think as a nurse is an ongoing issue for people, So it's that poor attention, poor concentration, those constructive skills, how you put a plan together, your sensory and perceptive function, language, memory, mood, all of these sorts of things, your executive functioning, planning, learning new tasks. So even if you had, issues in an area where you'd forgotten to do something, where we could relearn that task. Some of these patients, some patients just have the inability to relearn those simple tasks and that intellectual function. So I just think a lot of the neurocognitive stuff, it's not just the patient it's affecting, it's your return to work, it's your relationships that you have, and it's the relationship you've got with your carer, and it just affects the whole family. It's, you know, it's that whole family that get affected by it. So a little bit about what can be done. There's not massive amounts, as they were speaking this morning. It's you know, we try to get people into neurocognitive retraining and testing, but it's expensive. There's a huge out-of-pocket expense. There's a bit of difference with who you go to, you know, and how good the neurocognitive testing is. And I mean, I used to send patients off for neurocognitive testing and they'd give me a 10-page list of what the issues were, but weren't going to tell me how we were going to go about fixing them. So it's all good and well knowing what the problems are, providing that you have got something in place to actually do the brain retraining and things like that. But there is a specific neurocog brain training sort of thing. So if you get linked up with a neurocognitive OT that does that specific stuff, they use a lot of these tools that'll get you back with your memory and stuff. And as Helen Wheeler was saying earlier, we've had a whole handful of patients that we've sent off for neurocognitive testing, and they've done it's a lot of hard work, and it's like going back to school and you've got to put the hours in, but they have markedly improved with their thinking and processing it. It does work. It does actually work. And then the big one that I see a lot, and I seem to get lots of emails sent to me about, is the Lumosity one, which is on the, you know, you can just Google that and get it on the website. But you still got to put your 20 minutes in a day and do the hard yards. So all of this, in my mind, you know, all the neurocog changes and the memory changes and the stress around, you know, the diagnosis and the change to relationship, inability to work, inability to drive that affects the patient. In my mind, it's a massive impact on the carers, and a lot of what I do is really supporting the carers in trying to, you know, care the best without massive burnout, because you do see some carers have really got to look after themselves, you know. And I'll say to a lot of the wives that I've got, you've got to give yourself time to go and get your hair cut, go and get your nails done, and do those things that you kind of enjoy, because if you don't get those things done, you're going to go crazy. Yes? So as we know, there's a frequent onerous care burden, and it's a very important complex role. You know, I teach people a lot about medications, how to manage seizures at home, and you know, one of the biggest benefits for me as a nurse is that if a patient's relative rings me up on a week, you know, on a Monday, and they've had a bit of an issue over the weekend and they've said to me, I've done this, this and this, and we've fixed the problem. And that to me is a real win as a nurse, because I've done my job in educating and supporting, you know, that carer in their role. But it's pretty full on. If you're a carer and all of a sudden you're giving medications and making that decision about increasing medication or giving a little bit more steroid to get yourself over the weekend, it's a huge ask, you know. A lot of the carers end up giving up their job or going part-time because the carer's role ends up, you know, that it's so many hours to be able to do that. The patient often the income is often the main income source. So, you know, because we do see a lot of men, the main income source comes from that, usually a young family in the patient groups that we see. Lots of clinic visits. I mean, I try, that's the one big thing, if I can do anything, is to try and get, you know, all the appointments on the one day, rather than you have an MRI, you see your surgeon, another week you see your radiation oncologist, and another week you see your medical oncologist. So, you know, if I can try and get them all on the one day, it's just one busy day rather than a whole month of busy visits. And then the home modifications and the hiring of equipment, putting ramps in, grab rails, you're completely changing your house sometimes, you know. And some of these things aren't funded. Some people have to end up putting a ramp in themselves and funding it themselves, or getting their brother-in-law who's a carpenter to come up and whack something in, you know. And then the financial issues in accessing superannuation. If I don't fill a form in every day for a superannuation, and I think the superannuation people and the disability people and the income protection people are there to drive me crazy. What's that? Yeah, oh gosh, you know. But look, you know, Helen Wheeler rings these financial institutions up and abuses them, but it falls on deaf ears. And I say to her, well, if we don't fill in the forms, the people don't get paid, you know, and really if you've got no income coming in, it's massive. And, you know, in my heart of hearts, I can't do that to people. But it's also accessing care allowance, disability allowance. If you've had anything to do with Centrelink, you know, and that, yeah, it's hard going, and that's me filling in the forms and probably furphying them a bit. And then the insurance reports, the ongoing insurance reports. So I don't know what a lot of, you know, if you've got insurance reports, whether your GPs do them or who the hell does them for you, but, you know, they're an ongoing saga, and it just adds more pressure on for the carer and the family, because as I said, if you don't get paid, if you haven't got money coming in, it's a massive stress. So all of this is around hugely needing to address and support that psychological and social well-being of the patient and the caregiver, and that part of it's absolutely huge. And I've got a little slide at the end here. I'll go back to that other one, but I do think the whole mental health around brain tumour diagnosis for the patient and the carer is absolutely, you know, really, really important. Around your emotions, the way you feel about things, that change in your relationship, the stresses around it, the anxieties, it can become so overwhelming. And, you know, consumes you to some degree. And I think this goes straight over to Catherine's talk, because the psychological support is really important. And I have to argue with patients sometimes to get them to link up and go to see somebody. But, you know, your mental health and how you cope with your diagnosis and how that impacts your family is really, really important. I'm just going to go back one slide. You know, because these main issues of that loss of income and increased loss of drugs and that inability to drive. So this slide was right up the front as well. But I think these are the main issues, and then the knock-on effect of that for patients is huge. So that's all I have to say, and I hope nicely this will go on to Catherine's talk now. Thanks very much. Ooh.
Clinical psychologist. She's worked in hospital and private care settings for the past 18 years. She currently leads a team of clinical psychologists at Headway Health, providing evidence-based interventions for people diagnosed with cancer and their loved ones. She's published numerous research papers, several book chapters, and co-edited a book on the psychosocial care of cancer patients. So we're very pleased to welcome you, and thank you for coming here today.
Thank you ever so much. And yes, look, some of the things I was going to touch on, Marina's touched on, so I may speed through some of my slides. I hope it's going to make no one dizzy here, but it's really so I can then...
And I'll have lots of questions at the end.
Okay. So. Is there anything that people want me to particularly talk about? I've obviously got my ideas about what I think might be helpful. Is there anything that people want me to cover? Yes?
Adjusting to the new normal.
Okay, yep. Okay, we'll certainly talk about that. Yep.
Yeah, it's fine.
Okay.
There will be questions at the end, Catherine.
Okay, all right. So I'm aware there's patients here, there's carers as well, and so I'm hoping a lot of the information I'm saying is as applicable to the carers as the patients. As Marina says, you know, carers do a vital job. They keep everything going, they keep the family going, they manage everything else. So we really need to think very seriously about looking after the carers, because if the carers are struggling, it affects the patient, as well as obviously being concerned about the carer themselves. So most people will say they never forget the moment they were told that they had a diagnosis of cancer. It's a significant life event. And while there's some similarities between people's experiences and responses, there's also unique differences. How old a person was, where they were in their life, where they were in their stage. They might have been about to start university. They may have just bought the camper van for doing their trip round Australia in their retirement. So there's similarities, but there's also very specific impacts for different individuals, different carers and different families. But for most, it's a pretty new and uncertain experience. And as we know, many different brain tumours, they're different diseases, they're treated differently. One of the great things about coming to an event like this is that you meet other people, but you also meet people that seem like they had a similar story, but then they're having a different sort of treatment. So it really sort of speaks to the uniqueness of everyone's experience. We don't all start in the same place or equally affected. Some of us might have had previous experience with cancer that impacts which has an impact on how we respond to this news. And as Marina said, there's a real ripple effect into many, many areas of your life. A lot of people say, look, with the physical side of things, with radiotherapy, I'm given an appointment time, I'm told where to turn up, what to do, what medications to take. But with the emotional side of things, there isn't so much guidance on how you deal with not being able to sleep at night, how to deal with the fact that you're worrying and worrying excessively. So it can be really quite challenging. You all know this stuff. You're the experts in the room. I don't really need to repeat this. There's obviously emotional responses, there's physical responses. A lot of people really talk about elevated anxiety, and we'll talk a bit more about that later. Can feel quite isolated, often quite out of control. All of a sudden, Helen Wheeler or whoever it is telling you when, what day she wants to see you and what to do, and when your neurosurgeon's telling you when your surgery is going to be. So it's really hard to even make any plans for, the next day, the next week, let alone 6 months down the track. A lot of people say they fear that they're really concerned about the impact on others as well, and being a burden. And obviously, there's not many people that hear the word you've got cancer without wondering what this means for their future health. So as well as those responses, we also know, though, that many people talk about hope, determination, often appreciation of life, and closeness to others. And most people will say they sort of often really swing between hopelessness and despair and hope and optimism. And this can happen over minutes, it can happen over days or weeks. So that can be really unsettling. One day people can think, we're going to be okay, I'm doing a good job here, and then something can happen and it all goes to custard. So yeah, this new normal is hard to actually define. It varies. Common worries. I think we've probably talked about this. This perpetual uncertainty. No quick answers. There's lots of waiting. A lot of people think, and family and friends saying, won't it be fantastic? You've only got this many more radiotherapies, or won't it be great when chemo finishes? Yes, however, now I'm waiting for the next scan, but I don't actually have the doctors and the nurses and everyone checking up on me every day. So people find it can actually be quite a scary place to be. Lots of room for ambiguity and interpretation. Not guarantees. Even when we think about these treatments and, the presentations we heard this morning, we talk about brain surgery and that sort of thing. This is a big deal. This is big stuff. The treatments are very invasive. They're prolonged, and pretty unpleasant actually. And again, what I often hear people say is because they've had treatment before, that everyone else thinks, oh well, you've had treatment before, or oh, you've had surgery, chemo will be easy. When in actual fact, there's a whole load of new things to get their head around and to worry about. So different worries at different times. I think we probably touched on most of these. The impact on how people see themselves, their confidence in their health, is huge. Obviously, the impact on how their femininity, the intimacy, body image. The impact of hair loss is really significant. Everyone else was saying, oh, don't worry, you know, it's only your hair, you're more than that. But for the person, they look in the mirror, they see quite a different person, and they feel the world sees them differently. And it's a constant reminder. So it's a bit hard to just forget it and get on with life, which is what other people might be encouraging you to do. We've said, you know, in Sydney, Marina's talking about, you know, a large hospital. She works at the difficulty of coordinating care. If you're out in Whoop Whoop, getting to the city, who's going to look after the kids? The cost of it, huge, huge issues, just adding to the complexity. Marina's probably touched on all of this. Each treatment's got its own side effects. Often you're sort of, you can be asked, particularly with those recurrent disease, to make decisions about different treatments, but you don't really know which one's going to work for you and what the side effect profile is going to be for you. So really quite difficult decisions. So let's talk about depression and anxiety. As a psychologist, this is what I spend most of my day talking about. We know it's a common experience for most people, and it can be a response to event, it can be from medication, or it can just happen. But for people who are undergoing cancer treatments, it's not rocket science, and you do not need a psychologist to tell you the rates are higher. You know, probably up to half of people will have symptoms, significant symptoms of low mood that may have a really significant impact on their life. These symptoms again can compound the physical symptoms that Marina was talking about, the difficulties making decisions, the difficulties with motivation, fatigue. All of these things can just, you know, work together to make things a bit harder. Obviously, we know if someone's in pain, it's going to wear them down pretty quickly. If they can't do the things they used to do that gave them joy, it's not a recipe for, you know, a good day. More treatments, more invasive treatments. If we have a family history or a personal history of depression as well, it's probably going to be likely that this might be a response. So these are people here, when they're looking at this list, might be able to relate to that, but then what depression might look like. And I think there's gender differences. I don't know whether people agree with me, but I think as girls, we're good at bitching, we're good at moaning, we're good at crying, we're good at telling everyone. Often guys, they might shut down, retreat a bit more, they might work longer hours, or, you know, slam the door a bit more. Do people sort of agree that sometimes there can be differences? So it's sometimes hard to pick up, particularly when we've got so much on. It is a completely an understandable response in this situation. So what's anxiety? Again, really common. Some of us worry more than others before this happens anyway. There might be a lot of physical symptoms. It could be racing heart. It could be sort of panic attack symptoms, thinking I'm going to have a heart attack, I'm going to die, I've got to get out of here. It could be trying to sort of get super in control about things, or get a bit obsessive. And it can be acute, it can be around having an MRI or around a new chemo starting, or it can be more chronic. And people often use the word scanxiety to talk about what happens the night before a scan and while you're waiting for the results. Do people relate to the sort of the ups and downs of the anxiety? So this is what it might look like. Again, mood changes and also behavioural changes. So these responses are to be expected, but also they're treatable, and we mustn't just assume that they're part of treatment. It's really important to, I would dearly hope Marina, and I know Marina does, but your treatment teams and various people in your treatment teams will be asking you about how you're travelling, how this, the impact on life, but you might actually need to let them know as well. And you might find, look, you've got a really good GP that listens well, and they might be the best person to have this conversation with. So the sort of psychological interventions, which I'll touch on, there's certainly a role of medication, and there's certainly a role for both of these. I think I was sort of talking about gender effects before, and I think, you know, given the numbers that of men that are affected by brain tumour, it can be particularly hard. It can be, as Marina said, often they might be working in a successful job, they have expectations of themselves, but the world has expectations of them about how, you know, that they need to be in control, they need to fix things, they need to be self-reliant. Often the family might suddenly decide, though, that they need to talk about this, and they're not talking about this, but someone may never have spoken a lot, and they're not suddenly going to start emoting all over the place. So it's about being respectful of people's responses, but also trying to help them. So carers, as we all know, can be profoundly expected. They're expected to provide support and to know what to say and do. But we often don't, and we often get it wrong. I mean, we may well get told as well that we've got it wrong. They often can't say, this really sucks for me, I'm having a hard time. You know, everyone's phoning up and saying, oh, how's Ron? But they don't always say, and how are you, Mary, as well. So everyone sees you as someone that provides care rather than actually needing care in yourself. What the research tells us, when psychologists have done surveys on this, and the Cancer Council have done research on this, if we look at rates of depression and anxiety, they may be the same or higher than the patient themselves. Some of the concerns, and my PhD research looked at needs in cancer patients and partners. Some of the worries and the concerns they shared, but some were unique. And a lot of carers will say that watching someone else going through something and witnessing suffering without being able to do anything about it, or feeling that they can't do anything about it, is really, really tough. And I've certainly seen people who have been the cancer patient themselves and then been a carer, and they normally come to the conclusion that one's not easier or harder than the other. They're just really different, but both need support. Relationships, they're pretty tough at the best of times, aren't they? You know, you think what happens in parking lots when you're trying to decide what spot to go into. It tends to be when myself and my partner will have a Barney. You know, we're talking about having conversations about pretty profound and deep and meaningful things, making, you know, difficult decisions at a time when both partners are probably the most stressed they've ever been in their life. They've got to learn this all sort of complicated information, navigate who's who in the zoo, and you know, how to move forward. Also, you know, we hear different things. You go to a consultation and one person might leave thinking, oh, that was really good news. The other person might think, oh my goodness. So, you know, even the same information we process differently, and we adjust at different rates. So we're not always in the same place, which then means, you know, if we are in a relationship with a partner, we don't always get the support that we might be needing at that time. Intimacy. Intimacy is very often quite fragile. It can be affected by a whole range of different things: physical health, fatigue, stress, but needs and responses may change. And again, you know, people need to navigate that. For people who don't have a partner, we know that is a risk factor for distress. Again, you don't need a psychologist to tell you that. To go home to an empty house after you've had chemotherapy treatment, you know, that's pretty tough. And if you're thinking about a future relationship, you know, it's tough at the best of times, isn't it? Without sort of saying what you've been doing, you know, the last year, you know, in and out of hospital or having other treatments. So roller coaster ride. How am I going for time?
Well, we're a little over time now.
Okay. So let me just flick through. So the tools that can help. I think if we think very simply about stress as a seesaw, it's the balance between the stressors we've got on that end and the sorts of resources and strategies we can use to cope. So whether you're a patient or carer, thinking about what are the boxes on that end, and what can you add, what can you do, what can you make work better on this end. So accessing information, making a plan. The Cancer Council's fantastic at providing support in this way. Communicating with your team well, finding a team that really works for you and you can be confident, can ask your questions. Building on your resilience. A lot of people will have had other stresses in their life, and they can think about what has been helpful at those times? Can I dust that off and do that again? It might be as simple as getting out for a walk every day. It might be as simple as watching your favourite TV show. You know, if it's cheap and easy, it's more likely to happen. Retreats are wonderful, but let's face it, not always practical. So thinking about what you bring to this. Thinking about nurturing your well-being, exercise if that's possible, getting help with sleep and pain, nutrition, thinking about what gives you meaning in life. Where are your purpose? Where's your values? What is still possible? So this might be looking at each day, each week, and the every so often things. Working out with your support networks how to make them work for you, you know, how to manage offers of support if they're coming, if they're not coming, how to access support. A lot of people find when active treatment finishes, everyone disappears to the woodwork. You're more anxious because you're not having treatment. You're still exhausted. You're still seeing the doctors a lot. They're thinking it's wonderful, it's over. You know that it's not. And so there can be a big gap. And that's often actually where myself and my colleagues would meet people for the first time. Lots of great resources out there, which a Google search quickly brings up. The people here in this room probably all have different strategies that they could share, different things that work at different times. So for looking at fatigue management, social contact, support group, connecting with others, having fun, just having time where we're not thinking about this, really important. Thinking about professional support. So we have a whole care team, and one of the reasons I love working in oncology is that we work very much in a team, and we can all work together. Professional help, probably important if you're finding that you're wondering how to get back into life. What does this new normal look like? If you're recognising any of those symptoms of anxiety or low mood, you're not sleeping, not really enjoying life, if you're having physical symptoms that aren't related to your health, others tell you you're not coping, that's not always particularly nice to hear, or you just want to take the opportunity to work out where to now. So Medicare provides support with GP mental health care plans. And as was mentioned, I work with a team of clinical psychologists. We all specialise in cancer and work in a number of different clinics. And Jessica also provides a specific intimacy clinic as well for people who want to address that area of their life. We also have a dietitian to help with actually translating what some of the research tells us about what you can actually do as far as your diet and health. So in sum, range of emotional responses are to be expected, but there's lots of things that can help. Most people find that with time and with support, they work out ways of living with the challenges of treatment and their situation. And it might be surprising, and some people probably feel like punching me when I might mention this, but some people will actually report growth, and there might be changes in their relationships or priorities that have been something that they've been able to take from this. So.
Catherine, thank you very, very much. We'll have some time for some questions. So I know the girls have given us a very good overview and touched on a lot of things that obviously would affect many of us in the room, or probably all of us. But any questions from anyone in particular? You can address them to either Catherine.
Anyone got interesting sort of coping strategies or things that they could share as far as they found has been helpful?
Anything anyone does? Yes.
I'll just yabber. What I've found hard to do but necessary to do is take whatever control I can back off what's going on and look ahead to where I might be and taking the steps to go there.
Mm-hmm. So living as if you have a future and making plans and
well, and it might not be in that detail,
right.
But you've changed your perspective from what's behind you and what can be in front of you, which is really, well, it takes years to do that, but it's a gradual process of turning your, not capside boat, normal boat, around a bit.
Yeah. Yeah.
My only question was, when can I make an appointment?
And an opportunity to talk to all our presenters a little little later. You're staying on, Catherine?
Yes, I am. Right. And I guess, you know, hopefully there'll be things that you related to. There's flyers out there if there is any, if you are interested.
After tea, there will be an opportunity to speak independently with most of the speakers here today. So I'd urge you to have a quick cuppa and then go into the main room where they'll be gathered, and you can single them out and ask them some questions that particularly relate to you. Any other questions that anyone would like to ask?
I find it frustrating. You tell people what type of cancer you have, and you know the ultimate prognosis, and a lot of them go, "Oh no, you'll be right. You're looking fine."
Yep.
I think that's
makes you want to punch them, does it? Yeah. You won't be.
But I think that when you get diagnosed with a brain tumour, you've got your circle of friends, and you find what happens is some of your friends that were sort of a bit your associates, all of a sudden are coming around every 5 minutes and cooking your meals and all of that. And other friends that were best friends all of a sudden take off, and you think, what's happened here? You know, so, and it's just their emotion about what they're feeling about your diagnosis. You know, and that can be really different for different people. But people will always, I mean, even I'm bad at that, where I'll see one of my patients and they do look great. You know, and I'll say, wow, you're looking great today, you know. But I know that things,
So when
things are different. And
don't think like that. They say, don't think like that. You have to think positive. Well, I'm positive. I'm realistic.
Yeah, and that can just make you feel a bit more alone and isolated, can't you? And that people don't get it. One of the slides I flicked over was the top cliches and platitudes people tell me they hear, and we might spend our whole appointment dealing with how to actually deal with everyone else and everyone's unhelpful things that they say. Often the heart's in the right place, but not helpful.
The other one my wife complains about is, it was 12 months ago, get over it.
Absolutely. Yeah. A good one for the supermarket is, did they get it all? Are you going to be okay? You know, that tends to be by the frozen peas, that question will come out. You know, what do you say?
You know, all suggesting to go to a different surgeon, you know, you got to go to a better surgeon. So I think you just take it on.
I find it hard, I think, these days not to have an instant fix for everything. Everyone expects that everything can be fixed. And when you're confronted with something that can't be fixed and that you know you've got to live with and deal with, it puts you in a different place. So yes,
it's frustrating. I just think, aren't you listening to me?
Sure. And people don't know what to say. So rather than saying, gosh, I'm really sorry, I just don't know what to say, they rush in with you'll be right and all that sort of, or why don't you try this diet or juice a bit more, or or my friend in America, or Women's Weekly had a, article.
You haven't had surgery, it's right now.
It's just the start.
And you don't always have to say, when they say, oh, how are you? You look great. You don't always have to say, I'm okay, thanks. So actually, I might look alright, but really I don't feel terribly good. So I think a little bit of honesty, and that sorts out your good friends from the also-rans, I think, to some extent.
There's just a question here, Karen.
Do the people who were pessimistic before they had diagnosis become more pessimistic, or do sometimes they change and become more optimistic, like the glass half full before and half empty?
Look, I don't think there's any rules at all. What we do know is the research into positive thinking tells us, it doesn't make a difference on prognosis. Everyone would say, "Oh, just be positive." What we know is that if you are actually not depressed, if you're able to function a bit better emotionally, you're probably able to get out for a walk and see your friends and actually enjoy life a bit more, and that's really important. But yes, if you're coming to this and you've already on antidepressants being treated, this is obviously going to be, a huge challenge.
Another question over here.
I guess even coming here today, it's been great, and it's actually been affirming in hearing the treatment and thinking, yes, we've done all that and we've done everything that could possibly be done. But I also, when I'm hearing people who are advocating and pushing for new drugs and stuff like that think, oh God, am I being too passive and just accepting this diagnosis, and should I be pushing more for Steve's sake to so there's, I get that question of whether I'm doing okay as a carer becomes, you know, it becomes a guilt trip. I should be out there doing something more.
You can only do what you can do.
And look, a lot of people say, you know, what I've actually done is I've found a treatment team I can trust. That's their job. My job is helping with the day-to-day. And actually, and look, I've seen medical practitioners themselves who have had a cancer diagnosis, and they say, look, I haven't read anything up on it. In actual fact, I've chosen my treatment team, and I'm leaving that to them. So it's not a sign that, you know, there's no rules about how you should cope and what you should do. So it's very individual, and it changes at different times as well. Often in the early stages, people are Googling, but often when they get a team they trust, they get Marina, they just pick up the phone and they ask those, and they don't need to, you know, do a 10-hour Google search. So
You get different personalities, you
Yeah.
know. I can pick the engineers and the accountants now because they come in, everything's in spreadsheets and folders, and, you know, and they do question. But you've got different types of personalities as well. That,
and you're doing your best. Everyone's doing their best.